Okay. Hello, everyone. This is Priyanka, your host for the webinar. A very warm welcome to all the panelists and the attendees. And as we move ahead with our webinar, which is on proton therapy and sarcomas, I would just like to briefly take over what we are going to discuss and what would be your takeaway from this webinar. The objective of the webinar is basically to create awareness among the general public on this newfound technology, which has just emerged, say, about 2 years back in India and is now catching up. And most of us are at times unaware of what are we talking about. So we have basically come together, doctors from US and India, where they are discussing the best scenarios to benefit the patients. And we as individuals, general public, the patient and the families would get an opportunity to ask questions to the panelists. You have a question answer tab at the bottom of your screen. Please use it throughout the webinar and we will take up the questions by the end of it. This would definitely help you clear your thoughts, your confusion on the technology, and also get a clarity. Now, I would, without further ado, take on the formal introduction of our panelists. I would start with the senior most panelist with us, Dr. Mayil Natarajan. Sir, it is an honor to have you in the panel, and it is my honor to introduce you to the panel and to the attendees, and I hope I do justice. You're so decorated, and to compile your achievements and your professional expertise was, I'll just take over. Dr. Mayil V. Natarajan, an orthopedic surgeon. Dr. B.C. Roy Awadi is working in Chennai, India. A noted Indian surgeon who has made substantial contribution to the specialties of orthopedic oncology, medical training, health administration, medical ethics, and intervention of custom mega prostheses to avoid amputation for bone tumor patients. For his effort, he was awarded the Padma Shri by Government of India in 2007 and elected Fellow of National Academy of Medical Sciences. He was the 7th Vice Chancellor of Tamil Nadu, Dr. MGR Medical University, Chennai.
Thank you. That's enough, I suppose.
I would now like to introduce Dr. Matt Spracker, Assistant Professor, Radiation Oncologist, Washington University, St. Louis, USA.
Thank you.
Dr. Arpit Chabra, Director, Education and Radiation Oncologist, New York Proton Center, New York, USA. Dr. Mudit Chaudhary, Chief Resident Physician and Radiation Oncologist, Rush University Medical Center, Chicago, USA.
Thank you.
Dr. Srinivas Chilukuri, Senior Consultant Radiation Oncologist, Lead Bone and Soft Tissue Tumor, CMT, Apollo Proton Cancer Center, Chennai, India. Dr. Akshay Tiwari, Head and Associate Director, Musculoskeletal Oncology, Max Institute of Cancer Care, New Delhi, India. And the moderator for our webinar, Dr. Vivek Verma, Senior Consultant and Unit Head, Bone and Soft Tissue Cancer, Max Super Speciality Hospital, Ghaziabad, India.
Thank you.
With the introduction, I would now like to hand over to Dr. Vivek Verma to moderate the webinar and to begin with the medical discussions.
Thank you, Priyanka. So I'll just start sharing my screen. Good evening, everyone. All the faculties, senior faculties here, my friends, and many of the attendees who have joined us to learn about the sarcomas. So this is a very interesting webinar and it was initiated by Priyanka Banga, who is also founder of the Sarcoma Cancer Care Foundation. So as we hear the word sarcoma, it comes to our mind, what is sarcoma? So the most common question that comes out, is it a cancer? Is it a tumor? Or what does it mean? So my presentation is very basic to just highlight few points, because many a times we get confused when we hear these words as tumor or cancer or sarcoma. So are these all same thing or it is different? So let me just explain that if there is any abnormal growth of tissue or swelling, so it is called a tumor. So tumor does not mean that it is a cancer. It is an abnormal growth. And it may be a benign or it may be a malignant. So what is the difference? Benign means something which is slow growing and usually it does not spread to other parts of the body and is not a life-threatening type of disease. But on the other hand, the malignant ones are like which are aggressive tumors and tend to spread quickly to other parts of the body and can be lethal if not treated properly in time. And most of the times, these require a multidisciplinary approach. So unlike benign tumors, which sometimes can be just observed without any treatment or may require a surgery, on the other hand, the malignant tumors mostly requires a more massive type of surgery and massive type of resections along with chemotherapy and or radiotherapy. So some basic facts about sarcomas. So these are very rare tumors. If we compare other type of cancers like oral cancer, breast cancer, lung cancer, so the sarcomas constitute only 2% of all these cancers, the bone and the soft tissue sarcomas. Why they are called sarcoma? Because usually scientifically, these tumors which arise from bone and soft tissue or scientifically from the connective tissue, these are called sarcomas. And so they can be found in any part of the body. It can be seen on the face, it can be seen inside your body in the muscles, from the nerves, from the blood vessels. So it can arise from any part of the soft tissue. If we talk about example, many of our patients must have also joined, so they will be familiar with these names like osteosarcoma or other sarcomas. So when we talk about benign tumors, like I said, the simple way is to know that mostly they are the terminologies from a cyst, uh, bone cyst, aneurysmal bone cyst, or fibrous dysplasia like that. But once it is a malignant, it is mostly the terminology ends with a sarcoma, and even we have like osteosarcoma, Ewing sarcoma, chondrosarcoma, and a bit different biological group like chordoma. So why are we here today discussing about all these? So in 1903, the first flight which took off. So nobody had dreamed of how it will go into the future. And you can see the structure, how it was bent. And now if we see today, the flights what we have, they are totally developed. They travel faster than the sound of the speed, can take you within minutes here and there. Similarly, in the medical field, and particularly talking about these sarcomas, a lot of things has evolved over the last few decades, and especially if we talk about for last 5 decades, because the advent of chemotherapy, it gained a prominent role somewhere in 1970s. Prior to that, if there was a tumor, any type of tumor, let's talk about a sarcoma in a hand or a foot, it used to get amputated. People would just chop it off and remove it. But still survival was very poor. But over the time, we saw that gradually things improved with the advent of chemotherapy, the survivals improved. And chemotherapy was one of them. Apart from that, we noticed development in the mapping system, like we have now MRI, CT scan, PET scan, PET MRI, which can clearly map the disease, where it is located, which part of the body it is involving, how much bone or soft tissue has to be removed. And so we can preserve the part of the organ, and which is called a limb salvage surgery. The other modalities like radiation therapy previously used to be very simple cobalt therapies, and which progressed to linear accelerators and multi fold improvement in the precision has come over the now. And today, like the webinar is on the role of proton therapy, which is something one of the latest modalities which is used in the treatment. Apart from that, very important improvement has come in the understanding of the biology of these tumors. Before, we used to think that these tumors are only something which is locally a problem, and treating that local problem will solve the disease. But now we know that no, it is a complex interaction at multiple levels, at the cell level, at the biological level, and it also needs to be handled well. That's why we have newer modalities of drugs which can target at very specific points. Another important development is in the field of surgical innovations. Like Professor Mailwan and Natarajan was saying before, in 80s when he started, there was very primitive prosthesis or no prosthesis, but then it led to the development of many indigenous prosthesis, by which we could achieve reconstruction after tumor resection. Prior to that, if we had to resect a tumor, patients would go for amputation because there was no modality to reconstruct that defect. But once you have a reconstruction tool with you, we can do a limb salvage with this prosthesis. And there has been, with the evolution, the cost of these prostheses also have come down, and it is very much in the affordable range of everyone. So if we talk the current situation in sarcomas, in bone cancers or soft tissue cancers, the risk of amputation has gone down drastically, and we are able to achieve limb salvage in more than 90% of the cases, unless it has been contaminated or it is a mismanaged case. Most of the times we are able to do limb salvage procedures. But what it is that has led to the improvement? So actually it is not just one aspect, but a multimodality approach. Like I said, what is the multimodality approach in the treatment of sarcomas? So we have the advent of these surgical tools, better planning because of the proper imaging, location of the tumors, with the help of precision tools like computer navigation and 3D printing, 3D planning. Then we shrink the tumor with the chemotherapy. We kill all the circulating cells, and especially to kill the other areas where beyond this tumor, where the tumor has gone beyond, we use radiotherapy, especially in situations where we are not able to take out the tumor completely. Radiotherapy has gained a very prominent role in improving the outcomes in terms of prevention of local recurrence as well as improving the survival outcomes. So just a few examples, like this was a case where you can see on my screen on the left side, there was a tumor, which was osteosarcoma of the distal femur. And we know that when we plan treatment, we have to understand the biology of the disease. Some tumors are chemosensitive. Surgery as such is the main modality of treatment to remove the tumor out of the body. But the cells are in circulation, we need to take care of that, for which chemotherapy is given. So in bone tumors, as such, surgery and chemotherapy have a very prominent role, and radiation plays a little bit lower role compared to these. But in soft tissue tumors, most of the high-grade sarcomas require proper radiation, multidisciplinary team with radiation, chemo, and surgery. So here we can see that how we remove the tumor. It is resected out, and this is what we use. And you see the post-operative X-ray. Some other developments in the surgical field, like this case where there was osteosarcoma with a pathological fracture, you can see, and the tumor had contaminated the entire length of the bone. So nowadays we can replace the entire bone with this prosthesis, and this is called a total femur replacement, where we change from the hip to the knee completely. Still evolving, and I would say the evolution where we are modifying that. Sometimes rather than removing the tumor out of the body, we can sterilize the bone while it is inside the body. And this is the use of cryotherapy. So this is the use of liquid nitrogen in which while the bone is still attached inside the body, we can sterilize this bone and we can put it back by killing all the tumor cells. So something called cryosterilization. In very smaller kids where we cannot use prosthesis or other modalities, so we can have still different types of procedures, and this is called rotation plasty, where we remove the tumor bone like femur, and then the limb is put it back, which is called a rotation plasty because the leg is rotated almost 180 degree. So these are all various innovations, developments in various modalities which have led to successful outcomes. And if we talk about successful outcomes, I would say different studies have quoted different like 5-year survival, which ranges somewhere between 60 to 80% in a good center in a non-metastatic case. By non-metastatic, I mean when the tumor is just localized to one part, it has not gone to other parts of the body. So it has a good fair chance of survival. But still, in some certain situations, there are limitations. Because as a surgical principle, when we have to remove these cancer cells out of the body, we have to make sure that it is taken out completely. But in some locations, like you see, this is a spine, and we can see these vertebra, and you see that multiple level, there is change in the bone, there is some soft tissue component, and behind what you see is the spinal cord, and there is tumor involving that spinal cord also. Similarly, here you see this is our lower part of the spinal cord, which is called sacrum, and which is involved by a tumor called chordoma, which has destroyed the bone completely. In these locations, you cannot remove the tumor completely out of the body. And here, what is very important that we should have a modality which can kill these cells and achieve cure out of it and improve the local recurrence, improve the overall survival. So I think this presentation and talk will take you through this journey, where at one point where we come to a halt where we cannot treat it completely, we have to rely on multimodality approach, and we'll see how the recent advances in the radiation treatment with the proton therapy can help us achieve cure in all these things. So this is our team at Max Institute. This is the East Zone team. We are in total, we are around 100 oncologists, and this is a team from the East Zone, around 50 oncologists. We take care of different organ-specific cancers like breast, head and neck, GI, musculoskeletal, etc. So next, I think we have seen the challenges which we face, and so how to overcome those challenges and what is new in that. I would hand over to Dr. Srinivas, so who would introduce us to this new modality of treatment. So Dr. Srinivas, I hand it over to you, so you can take over from here.
Yeah. Good evening, everyone. I first of all would like to thank Ms. Priyanka for inviting me. I think she's doing a tremendous job in getting us all together and making us speak to people who are interested in knowing sarcomas. Well, we wouldn't call ourselves sarcoma experts because we are still learning about sarcoma, and it's a challenge really compared to other tumor sites that obviously, because they are rare, we need to individualize the treatments, and yet we need to follow certain basic philosophies of evidence-based medicine, and it is extremely challenging. And last week, we learned something about sarcomas in the abdomen, in the retroperitoneum, whether radiation would be helpful or not. And so there are multiple nuances which we need to learn, and but it is still big enough field for us to get educated and and try to spread the awareness about sarcomas. So this talk was supposed to be taken by Professor Laskar, Siddharth Laskar, who is also who was my teacher when I did my MD 15 years ago at the Tata Memorial Center. So 4 hours ago, he called me and mentioned that he had a personal commitment which he could not come out of, and that is why I'm here speaking about what is proton therapy. And of course, I work at the Apollo Proton Cancer Center, and for all the audience, I would be, obviously it is for general public, so I will try my best to make sure that I don't use too much technical words. And in the next few slides, I would like to tell you what is proton therapy. Before coming to proton therapy, I think Dr. Vivek very nicely mentioned about what are sarcomas and how they are treated, and surgery forms the crux of the treatment for sarcomas. Indeed, it is true, but radiation therapy and other therapies also do play a major role in caring for these patients. And radiation therapy is one of the oldest anti-cancer therapies known. It's been known since more than 100 years. And how does radiation therapy work? Radiation therapy basically induces DNA damage, which is either single-stranded or double-stranded. And we all know that DNA, which is essentially the life of any cell, is if you damage that life of the cell, the DNA damage leads to effectively killing or sterilizing the cancer cells. And radiation has direct or indirect effects on DNA. So the direct effect is when it by itself can cause DNA break, or it would react with other chemicals such as water, which is the most commonly available chemical in the body, and it forms certain reactive species or unstable species, which leads to a chemical lysis of the DNA. So these are the direct and indirect effects of radiation therapy. And when we speak conventional radiation or X-ray therapy, the indirect effect predominates, which is reactive species formation because of certain chemistry, and then that leading to DNA damage is the predominant effect, and a small direct action is there. But if you see a radiation for bone tumors, and that has also been practiced since several decades, but there are several bone tumors. There are tumors such as something called lymphoma or multiple myeloma, or even plasmacytomas, where you need a lesser dose of radiation, but you have certain tumors which fall into the category of sarcomas, where they need a very high doses of radiation to achieve a good control over the disease. And traditionally, these were put in a basket and they were labeled as radio resistant. And indeed, they were not radio resistant, but they needed much more doses of radiation to get controlled compared to the more radio sensitive tumors. And typically, we use surgery is a predominant treatment in most of these bone tumors. So we combine radiation with surgery. So sometimes we give radiation before surgery, we call as preoperative treatment. Sometimes we give it in a definitive setting where the surgeon says that it is not possible to resect a particular tumor without causing a significant amount of physical handicap or structural deformities. And in that situation, we jump in and we probably sometimes offer definitive radiation therapy in sarcomas. There are also situations when the surgeon operates and we feel that there could be disease still left over by the surgeon, or it could be even microscopic. Despite the surgeon removing whatever is visible, there could still be microscopic tumor within the area where the tumor was resected. That would need certain amount of further treatment, adjuvant treatment, to ensure that there is a good control over the disease. And sometimes we use teletherapy. The most common type of radiation is teletherapy, which is external beam radiation therapy, which is given from outside the body. Sometimes intraoperative treatment is also given from outside, or in fact, we put the radioactive needles. We put needles into the tumor and then send in some radiation into the tumor. So that is also called brachytherapy. So these are some of the commonly used settings of radiation. Sometimes the surgeon takes out the bone and it is irradiated outside in a controlled environment, of course, and we can give very high doses of radiation. Once the tissue is irradiated, the tissue is brought back and it is implanted into the body. So that is called extracorporeal radiation therapy. And sometimes we do give radiation in situations where we are not able to cure the patient, but the patient has a lot of symptoms such as pain or bleeding. We intervene, and radiation is known to reduce pain and bleeding in certain situations. And that is not to cure the disease or control the disease, but essentially to palliate the symptoms, and that is called a palliative radiation therapy. So overall, as I mentioned, it is being less common. There are not many randomized trials. Randomized trial is one of the instruments through which we generate evidence, good quality evidence. Therein we subject patients to a randomized trial where about half the patients would go in for, say, experimental treatment, half the patients would receive the standard treatment, and based on which arm, which group of patients have better outcome, that is labeled as the new standard of care. And because these randomized trials are difficult to do in rare tumors such as sarcomas, we have to rely on prospective and good retrospective studies. And hence there's a lot of variation in when you give dose and technique and settings. And I'm sure you will probably also see some difference in how we treat sarcomas in different regions, different geographies, and in using different philosophies of treatment. So characteristics of X-rays, because the X-ray deposits a lot of energy in the beginning of its beam path. When it enters the body, it deposits most of the energy just below the skin. And as the X-ray travels across the body, the dose is significantly attenuated or comes down, and that is the reason why we need to make sure that when we give radiation, we don't include the critical organs, because the DNA damage can not just happen in the tumor, but it also can happen in the critical structures, and we wouldn't want that to happen. And fortunately, God is, probably, whoever has created us has made critical organs very unique in the way that there is a lot of capability of repair. So there, even though a little bit of radiation does go to the critical organs, that gets repaired, but the tumor is destroyed. So that is what we base our entire treatment on. And there have been significant advances in radiation oncology, as Dr. Vivek mentioned. So 20 years ago, when I joined, about 20 years ago, when I joined my post-graduation, Tata Memorial, 3D CRT was a standard where it's called 3D conformal radiation therapy, where we give to the tumor with 3 or 4 fields of treatment, make sure that it doesn't go through a critical structure, and make sure that the high dose region is received by the tumor, and the low doses are spread across the body, across the tumor, into the normal body. With IMRT came major advances where you can see that the high dose region, which is what we want the tumor to receive, is received only by the tumor, but the rest of the structures are where the dose is minimized compared to 3D conformal radiation therapy. This is called an intensity modulated radiation therapy. This is a slight modification of intensity modulated radiation, which is called a volumetric modulated arc therapy, which is very similar to IMRT. It takes less time to irradiate large structures, and you get a little bit of conformity. You see that the high dose region is restricted only to the tumor, which is marked in the red. The green one, which is slightly intermediate doses, is still going around the tumor, but the normal structures is actually receiving very, very low doses. Most of the normal structures are receiving low doses. So despite the major advances in radiation oncology, you still end up giving a lot of those to the critical structures. Most of the situations, we ensure that the normal structures do not they're not damaged beyond repair. We ensure, so certain structures such as spinal cord, brainstem are given extreme priority to make sure that they are not, they're not irradiated to high doses, and make sure that we don't produce significant toxicities in a patient. Then comes proton therapy. It's been there since a few decades now, but there have been a lot of advances in proton therapy as well. But what is unique about proton therapy is, I've already spoken about conventional X-rays, where you see that most of the dose is deposited just below the skin. But the proton has a unique physical property wherein it enters the body, but it does not deposit its maximum energy till it travels a particular depth. And that depth is called a range. So for example, a particular energy proton, most of times we use slightly higher energy protons, but whenever you use these protons, the dose deposited in the beginning of the beam path is very little, but it deposits majority of the energy in a few millimeter radius. And we call this phenomena as Bragg peak. Of course, tumors are not in millimeters, so we do a particular modification to make sure that the Bragg peaks fall inside the tumor so that the tumor is irradiated. But the characteristic of proton, which is there is no exit beam. So you see that there is absolute fall in the dose beyond the tumor. And there is no dose beyond the particular tumor. So you can see that the exit dose is significantly reduced. So for example, this was one of the first sacral chordomas which I've treated at the Proton Center 2 years ago. You see that this was very close to the sacrum, very close to the rectum. And we did a plan on VMAT, and we have a tomotherapy system, which is also basically a different form of IMRT. And you see that there is a significant low to intermediate doses to the bladder, to the urinary bladder, to the rectum, to the bones, the pelvic bones, and the marrow which is contained within the pelvic bones, and other structures such as bowel and other pelvic organs. But you see, if you see a proton therapy plan, since we used a few beams, we made sure, as I mentioned, there is no exit dose. And we make sure that the beam ends here, and we've ensured that the bladder receives almost no doses to the urinary bladder or to the pelvic marrow, or superiorly to the bowel. So you can see that the rectum is spared of most of the radiation. Bladder is spared. So this is the advantage of using proton therapy in terms of physical ability to spare normal structures and reduce the probability of collateral damage when we use radiation therapy. Apart from the physical aspects of proton therapy, physical advantages of proton therapy, there could be some biological advantages of proton therapy, which we are still trying to understand. There is certainly at least a theoretical advantage that along the Bragg peak, proton could be more effective than X-rays, could be about from 10 to nearly 50–60% more effective than on an equally effective X-ray radiation. So if you give a dose of say 70 gray of X-ray and 70 gray of proton, they are not equal, but the 70 gray of proton is actually equivalent to a little bit more, about 10% more of the effectiveness. So that is because there are multiple reasons. That is because the damage is very complex. The DNA damage is more complex, so it cannot be repaired easily, and there are other genetic and immunological factors. I will not go into detail, but there is some theoretical biological advantage as well with proton therapy. And with this, before the COVID hit us, we have treated a significant proportion of patients at Proton Center, and they were all there was a significant chunk of tumors were of musculoskeletal tumors. And this was the distribution. We treated about 42 till about March of this year. So thank you so much for giving me this opportunity. This is our Proton Center at Chennai. So this is one of the Proton rooms which we have commissioned about 2 years ago. Thank you so much.
Thank you, Dr. Srinivas. That was very interesting. And just to make it a bit more interesting for our general public, I will ask you a few very basic questions. So, like you said, the routine radiation, what we give are like X-rays, which kill the tumor cells. So just for example, if we have a tumor in pelvis, the conventional way of treating them with the radiotherapy was that it will, before it hits the tumor, it hits the skin, then it goes beyond that and finally hits the tumor cells. And then it also goes beyond. So the effect of radiation is seen in a lot of other areas as well, the side effects. But as far my understanding goes, like you said, you very well explained that with the proton, the advantage is that it directly, rather than losing its energy on the outside, it directly hits where the tumor is and gives all its energy to the tumor tissue. So I think this is a very important part where the radiation exposure and the side effects are reduced, which can be achieved with this proton therapy as compared to conventional form of radiation therapy. Is that right?
That's right.
Okay. So that was very interesting. And do we have any question in between? No, so far. So before we go on to the next part, we have Professor Mailvanan with us. So since Sir is the senior most and he has experience of many years, so I would just like to ask him how he has seen the growth and improvement in the treatment of sarcomas in the country. Because Sir was trained outside abroad, and when he came to India, the treatment of sarcomas was in the nascent stage. And I don't think people even used to touch those patients. They would just, if the diagnosis is there, it is a sarcoma, then people would say just leave it. Even now we see at many centers people say that you cannot do more. But Sir, please share your experience, how it has been over last decades.
Vivek, by calling me senior, you are making me feel old. The paradox in medicine is, old people want to become junior once again. So I'll call myself and say, junior orthopedic surgeon. Hello, Akshay, we can see you only now.
Yeah, hi, sir.
I don't know whether it's appropriate to talk about all that now, but anyway, since you asked, I have to tell you something. I remember attending the first International Society of Limb Salvage meeting in Saint Malo, France in '89. And I was only Indian, or one or two people were there. We saw the amount of work being done on tumors. At that time, chemotherapy had come in a big way, and it had laid the foundation for limb salvage surgery. The single event which made limb salvage surgery possible was chemotherapy. So I was sitting there in a huge crowd, and I saw the amount of limb salvage work being done. When in a country like ours, we were just beginning or we were not doing anything, I was astounded. I realized that if we are able to take back 10% of what you see there back to our country, then it's going to be a different world. And that was what happened. And being in Government General Hospital and Madras Medical College, which is the premier teaching institute in our state, we had a massive inflow of tumor cases from all over South India. So all the cases were coming with huge tumors, and then all of them were amputated. Quite a number of them said that we don't want our child's leg to be amputated. Can you guarantee this child is going to live? Then we will take them back and then die with the leg rather than have the limb amputated. Then the impact of having the limb was so great. Then I realized that you have to do something. The imported process at that time was about 4 lakhs. So how can it reach the common man society? So we found a man who was able to make the process for 40,000 rupees. It was 40,000. And Cancer Institute. I was attached to the Regional Cancer Institute in Adyar and the Government General Hospital, where we had a large number of bone tumors. Unbelievable, you know, an average orthopedic surgeon practicing in a medical college hospital or something like that, we see maximum one sarcoma in a year or something like that. It's very less. Here you had a large inflow of cases. And I was able to do something. So you had to do some research. So I said there was no ethical committee, nothing at that time. So I told them either you have a leg amputated, I'll put in this local prosthesis. We don't know what is going to work. And most of them said yes. And that's where the journey started. And the amount of gratitude which the patient had when you saved the limb, the whole family was happy and everyone was happy. And later on, when one patient after some chemotherapy developed secondaries, then we removed the leg and then he failed chest and died. The next day after death, the man's parents came to me and thanked me. Said, you fought for the limb for so long and then you fought for the life and now he's no more, but we are happy that you've been with us for 10 years. So you see the impact of losing a limb, having a limb. So that's how the story started, and then we started doing the work, and we found out that saving the limb is very, very crucial. You know, what is the price you will pay for the limb? When people say, you know, what is the cost of your upper limb or cost of your lower limb? No, it's unmeasurable. So the journey started, and we went on, and then of course the Tata Group joined in the year 2000, and then now I am aware of 20 states in India doing the work. It is not that limb salvage has reached every nook and corner. You must understand this. In 20 states, India has 33 states at least. And there are till 10 more states where still amputation is being practiced. Even today. And when I went as an examiner to All India Institute and PGH Chandigarh, the man boy answered me. I said, what will you do for bone tumor? He said, he'll do amputation. And I wanted to fail him. And then my colleagues refused. They said, we are doing amputation here. Why would you fail? I said, you see, it's 10 years down the line. We are doing limb salvage. The whole world is doing limb salvage. So we have now come to that stage where, you know, there were quite a number of people. IMSOS has now come up in a big way, and quite a number of people, youngsters like you, are doing a lot of work. So much is expanding. So this is the whole scenario which I am saying.
Sir, just to put on record, I also have had you as my examiner in my postgraduate exam, and I was so thankful I did not get a tumor case to present to you. So that's how. And the whole.
Where was this?
This was in UCMS, University College of Medical Sciences, Delhi.
Okay.
So of course we've all grown up, you know, admiring you and the lead that you took. Then whole country, you know, the whole limb salvage scenario in the country, I think, is indebted to whatever your contribution has been, and we are all following that.
And I must tell you, you know the number. I have personally done 2,500 cases of limb salvage custom process in 33 years. The largest single man series in the whole world. Not that I'm bragging, but then the fact is a fact. And you can welcome me when I come to get the Padma Award in Delhi next year.
Of course, we'll wait.
So that was a very interesting insight what Professor Natarajan presented, that how limb salvage has evolved, right? How he started making use of very basic instruments in the beginning, and now we have come to all the advanced type of prostheses, including expandable prostheses. So we have some more discussions coming on, and along with the cases. So we have different cases from US as well as from our Indian faculties. So let me start with Dr. Srinivas. So Dr. Srinivas, shall we start with your case presentation? And we will keep it a live discussion, and anybody who wants to ask questions can just put up in the chat box, or even our panelists can stop and ask about any query so that it is beneficial to all our attendees. So just to remind that for each case, we have kept 10 minutes, including discussion.
Yeah. So I'll be quick. This is a 33-year-old software engineer. Came from Nagpur, all the way from Nagpur, which is the western India. He presented with right hip pain since July 2019 and was on conservative management. He's very young, so he thought that it is something very benign. The pain increased in February 2020. So he underwent an MRI, which actually showed an abnormal marrow signal changes in the right sacral ala, iliac wing with extension to right acetabulum with soft tissue collection, inflammation around right iliacus. And the PET CT confirmed that this is a malignant lesion, fairly large, with good soft tissue involvement, and there is some marrow ossification in the right hemisacrum. And the CT guided biopsy was done, and it was called as conventional osteosarcoma. This is the T2 and T1 images. You can see that there is a large tumor involving the iliac bone, including the muscle, iliacus muscle anteriorly. Posteriorly is also involving the muscular planes, and there is some involvement of the sacrum as well.
Dr. Srinivas,
Yes.
before we proceed further, let me ask our faculties from US. So like in this presentation, a patient had symptoms since July 2019.
Yes.
And by that, initially he was treated conservatively, which means probably physical therapy or physiotherapy. And then
Yes.
I think only once the symptoms progressed, then he came to a doctor properly to get evaluated.
Right.
So Dr. Arpit, how is the situation there in US? What is usually the lag between the time the symptoms appear and when the patient presents to the doctor, or especially to the oncology department for the first time?
Thank you for that question. I would say that, you know, from the time that the symptoms appear to the time that the patient sees the oncologist is probably still, you know, a lengthy amount of time. But I would suggest, and I would say that here, what would potentially have been slightly different is that the patient may have seen their primary family medicine or internal medicine physician initially to note the complaints, and you know, I would have suspected that an X-ray at some point would have initially been done, which would have likely found some bony changes that would then have prompted additional imaging, such as a CT or an MRI. So I think while the oncologist would not have necessarily been the first person the patient saw, I think through the family medicine physician, they may have eventually gotten earlier imaging and then potentially seen an oncologist at that time point.
Right. So, Dr. Akshay, usually when the patient presents with a pain like that, and what is the threshold? Because nobody thinks of a cancer or a tumor in the first instance. We all feel that it must be some physiological sprain or something. So what is your threshold when a patient presents with a pain? When do we start evaluating in detail with a X-ray or MRI or CT scan?
Yeah, thanks, Vivek. I think we being sarcoma specialists, our threshold is going to be very, very low, right? And in fact, we often joke in the family that, you know, any symptom leads us to just one diagnosis, and that one thing is what we want to rule out always. But the message I think that needs to go out is because it will usually be the family physician, as Arpit just pointed out, or the family orthopedic surgeon in our case. And mind you, this was a well-off, educated young man who had maybe right gluteal or right hip pain. He could also be having some neuropathy or some radicular pain, which will be quite similar to the symptoms of prolapsed intervertebral discs. And that is where we all, as you know, trainee orthopedic surgeons, need to be educated that sarcoma always needs to be there at the back of our minds. Time to diagnosis is very, very crucial, not just for treatment, but also for the long-term prognosis. And I think the message to our trainee orthopedic surgeons is going to be very important there. To keep sarcoma as a first diagnosis is always very difficult, as just Dr. Mile pointed out. the average orthopedic surgeon will see maybe 1 or 2 sarcomas in a year, and this we are talking of a busy orthopedic surgeon. And as we keep saying in our meetings, as Arpit pointed out, an X-ray or an MRI, a quick MRI would have, or even an X-ray would have picked up this lesion. And I think, yes, sarcoma needs to be there at the back of our minds, even if we are not sarcoma surgeons.
Not subsiding. There is no point waiting for months, but we should intervene early and ask for relevant investigation. And I think X-ray is something which is easily available, and here we can just get it done over the counter at any center, right? So, Dr. Srinivas, please continue.
So exactly, that is what one of the first questions was to the patient. Since you mentioned this, then I asked, why were you with pain for so long? And he clearly mentioned that his wife just delivered, and initially it was typically blamed into saying it was an excitement, that is why you're having pain, and then you are lifting some things and that is why you have pain. So people kind of account to something or the other. And unfortunately, X-ray would have really picked up and would have raised a suspicion, raised a red flag to go for an MR. And unfortunately, anyway, this February it happened, and immediately then it was thought as a malignant growth. So immediately a PET scan was done. Fortunately, it was not metastatic. It was localized to the pelvis, right hemipelvis, and then underwent a biopsy. As I mentioned, the biopsy showed an osteosarcoma. We started on chemotherapy, received 2 cycles of chemotherapy till July 2020. Well, he went to many surgeons across Mumbai, it took opinions even abroad and everywhere, and then was decided that the surgery would be too morbid. So maybe I would like to ask the surgeons on the panel, what is their take on this particular tumor? I mean, I would also show the PET CT that was done in between chemotherapy. This was the MRI when the patient actually came to us.
Dr. Akshay, would you like to take this?
This was, I know it is not possible to tell, but S1 and S2 were clearly involved. So a good portion of S1 and S2 were involved.
Yeah, thanks, Srinivas. I think resectability is one of the most important prognostic factors which decide the outcome, particularly for osteosarcomas. And as you just mentioned, we can see it's not just the right iliac bone, the right pelvic bone, but also the sacrum, which is the last bone in the inner spine. And the tumor is, as I can see in these images, going very close to the nerve roots, which are going to supply the muscles of the right lower limb. As you said, we do not have all the images, and in case it is going up to the midline in one of these sections, we would call it inoperable. But it is also quite possible that the surgical morbidity, even if resectable, was not acceptable to the patient. Sometimes if there is involvement of the nerve roots, we can offer what we call an external hemipelvectomy, which is a limb sacrificing solution. And as we can, one would expect, the surgery is going to be quite morbid with the loss of the limb. Or if not the loss of the limb, then the patient is going to be left with a limp and a limb that is weak and numb. So I think both the scenarios could have been possible. Looking at these images, I would not say it is absolutely unresectable. You need to see more images, and then you need to counsel the patient as to the expected morbidity after a complete removal of this tumor. But yes, the situation is tricky, and I would, I would agree with the patient if someone says, I'm just not ready to accept that kind of a morbidity.
So, I just want to ask Dr. Matt about a step before we plan for all these treatment part. Dr. Matt, if a patient comes to the OPD like this, suspected sarcoma, or when it is referred, so who deals with it first? Whether it is the radiation oncology team or is it the surgical team? So where does it go?
It's a great question. So I think that in this case, at our center at least, we try to have people see everybody. So I have patients like this come through my clinic often because they were seen by their local doctor. They were determined to unlikely to be resectable. So they get sent to the radiation oncologist. But what I do when I bring them into our center is I'll have them set up appointments with our orthopedic surgeon and our medical oncologist as well. Because as you sort of implied, I think that whether a case can benefit from surgery or not is sort of dependent on the surgeon's interpretation of the case. And that can certainly differ between surgeons. So I want to make sure that the one that I work with the most is able to see them as well.
So usually it goes for a multidisciplinary team in a tumor board where you all can discuss and take the final call. Right. Okay, fine. So, so we know, looking at this scenario, that this is a very borderline case where it may be resectable, but if it is resectable, it would be associated with quite a large morbidity, because we may have to sacrifice the nerves, which may lead to weakness of the lower limbs, involvement of urinary or bowel control. So, Dr. Srinivas, what was planned and what was done exactly?
So before I proceed, I would like to re-emphasize what Dr. Akshay mentioned, that the patients need to be seen by, of course, an MDT setting, but need to be seen by at least 1 or 2 sarcoma surgeons, dedicated sarcoma surgeons, to make sure that, I mean, it is very easy to jump in and say that it's unresectable, but we know what surgery can do in this disease and how much of a impact it can have on outcomes. So it is very important to each patient to be seen by a sarcoma surgeon before it is whatever labeled as a resectable or unresectable, or resectable but would lead to a great amount of morbidity. And that is I think that should be one of the key takeaways for everyone who is attending here. So anyway, the patient was seen indeed by 2 sarcoma surgeons, eminent sarcoma surgeons from Mumbai, and who were actually my teachers, and they were convinced that that this is probably, after they had discussion with the patient, they said, I think, then they referred the patient, actually was referred by a sarcoma surgeon, and they were convinced that its surgery was not the best choice for this particular patient. And of course, we took it up for planning. We did the CT, we did the MR. This was MRI during the radiation planning. And we obviously treated the almost a significant portion of the sacrum, as well as the compartment. And then, I mean, you can see the dose distributions. Obviously, the challenge here was to make sure that that the bladder, urinary bladder, was treated to the least possible doses. The small bowel, which could actually come in and go every day, because bowel is mobile, as all of you might know. So we wanted to ensure that the bowel receives doses less than what it can receive. And of course, the urinary bladder, the penile bulb, the rectum, and rest of the pelvic structures, and make sure that the contralateral bone marrow is also not irradiated, because the patient is going to receive some chemotherapy post-radiation as well. So this patient is completed about a month ago, and we do as a protocol, we're doing a study prospectively of doing an interim MRI after 4 weeks of treatment, and we do see something called diffusion contrast enhanced DC MRI, apart from the diffusion weighted imaging, and we are trying to correlate the early response of sarcomas to the long-term local control. And that is why we saw, and we could see some significant treatment response within the tumor, not in the in the form of significant reduction in the size, but there was definite changes in the MRI characteristics, which actually give a window into the response of the tumor.
Can I ask something?
Yes, yes, Professor.
Vivek and Akshay, well, post radiotherapy, is there a role for excising this? Would you be happy to go and do something now?
Yeah, so osteosarcomas are extremely radio-resistant tumors, and that is where the value of proton lies. I think this decision needs to be made before you go in for radiation. And as proton therapy has been given with a curative intent, there is no role for reassessing for surgery. And in any case, you do not expect the surgical, involved area or the area that is going to be excised pre and post radiation. If this was Ewing sarcoma, radiation would have made a difference. But again, because Ewing sarcoma is very radiosensitive, again, it would have been a definitive radiotherapy. So I guess, at least for osteosarcoma, there is no role for reassessing for surgery after radiation.
Excuse me, Sini. We are talking about highly radiosensitive tumor like Ewing's and radiotherapy. Now, at that time, there was no proton therapy. So there's no saying there's no role for proton therapy in osteosarcoma. There could be a role which Srinivas, Matt, and others have to find out now.
Yes, so yeah, of course. So that role comes with a curative intent, not with a preoperative dose intent.
Vivek, I don't agree with it. Vivek, what do you think?
So, pardon me, sir, but I agree with Dr. Akshay. Because we know that osteosarcoma, it is a sort of, we don't say like a radio resistant, because everything is in terms of relativity. So we say in general, if we give the conventional radiotherapy, then we tend to see more of the recurrences sooner. But now with the advent of proton therapy, and this case where we are not expecting something where the margins are going to shrink, where we can go for a second surgery after radiotherapy. So here we are giving full dose of radiation with the intent to cure the disease. So I think in this case where the decision was taken, and the advantage of using proton therapy lies here, where the conventional mode of radiotherapy has shown the histology to be a radio resistant type. So here lies the main benefit of using proton therapy in achieving cure. I think any of our, sir, what do you say now, sir?
What do the others say?
Yes, sir.
I was just going to add one point to that, and I think it's a point that's been coming up throughout the entire webinar, but for the attendees, that multidisciplinary cross-communication, constant communication between the surgeon and the radiation oncologist is a must for management of sarcomas. Because for the radiation oncologist, it's imperative that we know beforehand if this is going to be a preoperative situation or if this is going to be an unresectable definitive situation, because that determines exactly how much radiation we want to give to these tumors. So, for instance, in this case specifically, Dr. Srivas, planned on giving 70 plus gray, which is the units of radiation treatments, because the intent was to make sure we give that patient the best chance of control, and that's where you need 70 plus gray. And the ability to do that, I think, is better with protons because of the fact that, as you can see here, there's a lot less dose getting to all of these other normal tissues, the bowel, the bladder, the rectum. And because the risk of toxicity is less, the ability is there to give even more dose, which is completely changing what I think the historical thought was about being able to control this. We do feel 70 plus gray gives this patient a good chance of control in a scenario where it's not resectable.
The other thing in this case is the reason this was considered unresectable is the initial volume of disease would have just made the surgery too morbid. And, excuse me if I'm wrong, or you can answer that from the surgical side, the areas at risk when you'd go back in, even after radiation, remain completely the same, even after getting full dose radiation. So even if we do see a good response, the amount of surgery you would have to do would still be extremely morbid. And this is a young gentleman, 33 years old, and just had a young baby. He's going to be running after his child. So I think it sounds like he wants to preserve his limb at the moment to be able to have the best quality of life. I think this highlights, that he's received excellent care from surgeons. Surgeons are thinking about his quality of life and not just trying to cut for no reason. So I think this really highlights that he had excellent surgery opinions in his care.
I think this was a well-planned case by Dr. Srinivas, and I hope this patient.
Dr. Vivek, I just would like to mention here that as you rightly mentioned, radio sensitivity is always relative. The fact that we could deliver this gentleman about 72.6, we as a practice for most of the sarcomas, we're doing something called hypofractionated. That means the normal fractionation is 2 gray per fraction, but we are routinely using slightly higher than 2 gray per fraction per day to make sure that we pack in more doses without increasing the treatment time too much. So we gave this 72.6 in about 6 weeks and 2 days, which is 32 sittings, which amounts to about 74, 75 gray. So this is the beauty of protons, where you could give very large doses without. The patient had, of course, some grade 2 skin toxicity, which was treated by using topical topical agents. But otherwise, patient tolerated it beautifully well without any significant toxicities.
Yes, I must congratulate you for taking the right decision, and it was a good team effort. And I hope that this patient goes on in for cure as well.
Vivek, just a quick one before we proceed, just for the benefit of everyone attending. Let us put this on record, and as Dr. Srinivas himself said, the treatment of osteosarcoma is complete surgical excision, and proton therapy is to be reserved for cases where surgery is not possible. Yeah.
Absolutely.
So let's move on to the next case discussion, that is by Fracker Matt. So Dr. Matt, you can start with your presentation.
Thank you. Let me share my screen here. Okay, so I'm going to present a case of an epithelioid sarcoma in the head and neck, which is a soft tissue sarcoma, a little bit different than the last case. So this case was of a 37-year-old female patient that presented a couple of years ago with a right facial mass. It grew slowly over 3 years, which speaks a little bit to what we were talking about earlier about sometimes delay of getting a diagnosis for a growing mass. They had a standard workup that led eventually to a PET CT that showed just the mass. And then this patient also had a single lung nodule that was actually biopsy proven to be a single metastasis for the patient. The patient underwent a radical resection of the mass in May of 2018. And then that pathology demonstrated this to be a high-grade epithelioid angiosarcoma. This was a 6-centimeter tumor and had negative margins. Because the patient had a single site of metastatic disease at this time, and because we thought that the histology was angiosarcoma, which is well known to be very aggressive in the metastatic setting, we elected not to treat with postoperative radiation at that time, despite normally we would in a case with a high-grade sarcoma that's 6 centimeters, even with negative margins. As I mentioned, the lung lesion was biopsied and was determined to be metastatic disease. So the patient went on a clinical trial and was treated with pazopanib for quite a while and did very well. And then shortly after they went on this trial, they added immunotherapy to the patient's chemotherapy regimen. Actually, the patient had complete resolution of that nodule in the lung and was without any disease. And then in December of last year, the patient then went on to have a local recurrence in the head and neck of where the prior tumor was. So at this point, really all that was left was this smaller local recurrent tumor in that area. Chemotherapy was tried at that time, and we were able to achieve stable disease with a couple of chemotherapy regimens. This is gemcitabine, taxane, and ADI, and then doxorubicin-based regimen. And then once we were able to achieve stability on this regimen, the question came up about whether she would benefit from resection of the recurrent tumor. So that was undertaken. The resection, before I jump ahead to the surgery, this patient had preoperative imaging that showed this tumor right here in the parotid space on the right side. This is a good image of it. Relatively small but recurrent, so 3.5 centimeters of maximal dimension. And then when we're worried about angiosarcoma or epithelioid sarcoma, we think a little bit about the involvement of lymph nodes in the neck. There was no evidence of that on the scan, so we moved forward to surgical resection of this disease. We decided up front to do surgical resection followed by radiation because a very intricate surgery was planned. The patient had a resection with a flap reconstruction, and I think in general at our center in the head and neck area, when we're planning a flap reconstruction, the preference is to use radiation after surgery versus before. So the surgical resection was undertaken in July. It included a right parotidectomy, a tumor resection, the right neck lymph nodes were evaluated with a dissection, and then as I mentioned, there was a free flap reconstruction. There was actually ablation of the external auditory canal with this surgery, so a bone-anchored hearing aid was implanted. These are devices that allow patients with damage or issues with their external ear to be able to hear on that side after a surgery. The only reason I mention this is it is an electronic device, so the bone-anchored part of this was placed during the surgery, and then the rest of the device that's on the outside of the body that's electronic was reserved to be placed until after we were done with radiation, so there was no damage to the device with the treatment. The pathology from this cancer, it was actually further classified as epithelioid sarcoma, which is different than angiosarcoma. And we were actually not very surprised by this because epithelioid sarcoma, while it's similar under the microscope, behaves a lot more like this case versus angiosarcoma. And what I mean by that is it has a propensity for local recurrence and well-behaved metastatic disease, whereas angiosarcoma tends to be highly aggressive in the metastatic setting. The final size was concordant with the imaging, and the tumor was found to be mostly viable, and the final margins were negative. Despite the fact this is a small high-grade tumor with negative margins, because it was recurrent, that was the indication for radiation for me. So we just opened a new machine at our center called spot scanning protons, or IMPT. IMRT was reviewed very nicely in the beginning of this webinar. And the idea is that the IMPT, compared to older proton machines, is able to shape the distal edge of our fields very well. So in my opinion, this machine is really exciting for the head and neck location because, as you all know, the tissues inside the head and neck are very sensitive to radiation, and giving a high dose to those tissues is associated with a lot of side effects in the short term and the long term. So my fields are shown here. We delivered a kind of a shrinking field technique, which is standard in post-operative radiotherapy for sarcoma. The original location of the tumor was here. The blue is my lower dose field, and the pink is my higher dose field. And then what I'm showing you here is just a composite of the entire treatment to the patient. 60 gray and 30 fractions is the dose that I use as a standard in post-operative radiation therapy after a resection with negative margins. I just wanted to show the dose volume histogram, which is a way that we look at dose delivered to both the tumor and the normal tissues. And it's a little bit complicated to read these, but essentially what you're looking for is this shows the amount of dose delivered to the structure, the percentage of the structure. So up here is 100% getting the dose along the bottom. At the end of the day, what I want to emphasize here is that we like our target or our tumor target to be over on the right here at the top, where there's lots of dose going to a high percentage of the target. And then your normal structures are all down here, and that we like to see them over here with very little dose going to small amounts of the target. And essentially what I'm trying to show here is that things like the oral cavity, the salivary glands, which are very important for producing saliva in the long term, the optic structures like the eyes and the nerves that feed the eyes, and then those get very, very little dose with proton therapy in this sense. So this is really where I think proton therapy shines for patients with head and neck cancer, sarcomas, because it can spare these structures. I think that's all I have for you today.
Interesting presentation, Dr. Matt. So just because some of our audience are non-medicos, so I'll just summarize it in a very simple way. So in this case, there was a tumor on the cheek area, which is the parotid, near the parotid. And during presentation, there was also a lung metastasis. There was a lung nodule, right?
Yes.
So in this case, you started with chemotherapy and then planned for resection with radiotherapy. Many a times, a general question what is asked by a common patients is, if you are able to take out the tumor completely, then why do we need to give radiotherapy? So can you just elaborate about it?
That's a great question. So I think this is an instance where we're lucky in sarcoma that we actually have clinical trial data to guide us. So the main reason that I do this is due to the factors that we know drive recurrences, and we know about these factors from studies of patients who have had surgery with and without radiation over a long period of time. So the things that we know make a high risk for a tumor to come back are a large size. In our case, large size generally means bigger than 5 centimeters. A high grade, and I think we've talked a little bit about grade, which is a score that the tumor gets that talks about how aggressive it might act. And then the biggest thing for me we've seen in our studies is that when a tumor has come back after a prior surgery, whether it's had radiation or not, that is actually the strongest predictor that it's going to come back a third time, in other words. So if it's come back a second time, the risk of it coming back again is quite high. This idea was actually tested in a clinical trial. So there was an old study where patients got a good sarcoma surgery by an expert. And then the question was asked where half the patients got radiation and half the patients didn't. And we found that if you didn't give radiation, even after a very good surgery by an expert, the chance of it coming back was higher than most oncologists are comfortable with. So we typically will offer postoperative radiation therapy to reduce that risk.
Right, very well explained that. And in fact, we know that when there is a tumor, there is a reactive zone around it. And probably there will be more satellite nodules or microscopic deposits beyond even the exact anatomical extent of the tumor, what is being seen on MRI or scans. So by surgery, we tend to remove it with a margin, but still there may be more satellite deposits around, which is very well taken care of by radiation therapy. So
that's an excellent.
Yes. Dr. Mudit, just a question to you. So what is the role if tumor is recurring again and again? Do you think giving a conventional radiation therapy or using proton therapy, will it make a difference in those situations?
Yes, I think Dr. Spraker, he did hit on it, and I think you also hit on it as well. Once you come back, it usually has already declared itself as being extremely aggressive. And these type of tumors, you want to do your best to try to get rid of it completely the first time, so it never comes back, or if it comes back the second time, to stop it then, because once it comes back after that, it's almost impossible to control it. So I think in general, some radiation has a role. Proton therapy, specifically when you're asking, it really depends on the location of it. This is an extremely sensitive location that we saw, and I will have a similar case to Dr. Spraker, and we'll show like where we were unable to do proton therapy, and you'll see how the dose looks indifferently in our treatment compared to what Dr. Spraker did. But if you look at where his tumor was, like it was almost adjacent to the regular brain. The brain wasn't involved at all, so it doesn't need to get exposure to radiation if it doesn't need to. So the brain is starting right where his dose is ending. And then right in the central area, besides for the bottom of the brain, that's the start of the spinal cord. And the dose that Dr. Spraker is required to give to achieve control of this tumor is higher than what we like the spinal cord to get ever. So for example, we like to stop the dose at the spinal cord, ideally at 50 gray if possible. He's needing to give 60 gray to try to stop the tumor to come back. And you can see that in this case, the spinal cord is only getting 25 gray. So we have a very high level of confidence that we will not cause a big toxicity to the patient while trying to stop this tumor coming back. which would not be able to be easily achieved as what without proton therapy in this case, what Dr. Spricker was able to accomplish.
Yes, right. So yeah, that is very important that when we are closer to these critical structures, sometimes the toxicity can be more discomforting to the patient than the tumor itself. So yes, we move on to the next case presentation, Dr. Mudit. So we're looking forward for your presentation now.
Okay, thank you so much for having me. I really am excited to speak with all of you. My name is Mudit Chaudhary. As we've mentioned before, I'm the Chief Resident Physician at Rush University in Chicago. I'm going to present a case on a recurrent head and neck pleomorphic sarcoma. Before I get started, I just want to share some information about Rush. So, and kind of hits what we've been talking about. So we're a US News Honor Roll hospital, meaning we're one of the top 20 hospitals in the entire United States. We're nationally ranked in cancer and orthopedic surgery, including the top 5 in the entire country of orthopedic surgery, among other specialties. And so because of that, we have a very large multidisciplinary sarcoma team that receives a lot of cases relative to most places. And when we talk about multidisciplinary team, especially in sarcoma, what we're talking about is surgical oncologist or orthopedic oncologist, which is usually the leader of the team, a radiation oncologist, medical oncologist, a special pathologist, because when you're diagnosing sarcoma, since it's so rare and it can look very tricky under the microscope. And so getting the right diagnosis is extremely tricky. And so you want to have someone who has experience in being able to diagnose it correctly. And then finally, a radiologist. In this case, we had a 66-year-old woman with a recurrent high-grade pleomorphic soft tissue sarcoma of the neck. She was initially diagnosed in 2008 and received a radical resection at an outside hospital. She was not offered, this was a community setting, and she was not offered any adjuvant radiotherapy. And you can see within 1 year, she had a relatively close regional recurrence in the lymph node area of the neck. She then now underwent a second surgery of the neck, central neck dissection in January of 2010. And this time she did receive adjuvant radiotherapy at an outside hospital and received similar dosing as Dr. Spraker has mentioned, 66 gray and 33 fractions. This was followed by some systemic therapy. So she did very well after some time, but unfortunately, 10 years later, she now presented with a rapidly increasing neck mass, and it was causing difficulties with her breathing. So this is just a few images that you can see in all 3 planes. And I've put a star on here for the audience so you can kind of understand what we're looking at. So there's a large partially necrotic mass in the central neck structure. It's completely involving the base of tongue and kind of involving almost the full tongue. You can see here it's kind of compressing the airway compartments in the central structure of the neck. But because it was causing symptoms, it required now a third radical neck dissection in her lifetime. And unfortunately, because of the extent of disease, they had to sacrifice the left carotid artery, the vagus nerve, and the sympathetic chain. She had a big repair, a pharyngotomy repair, pectoralis myocutaneous flap reconstruction. 1 month later, she again noted tumor regrowth, this time extending from the left neck to the right. And this time you can see a PET CT, so you can see the abnormal areas lighting up in yellow in this case, excluding the brain. Don't worry about that part, but you can see it's completely involving the same exact areas that it was initially present. So this time she came to our center. All her care prior to this has been at an outside hospital. We had a long talk in the sarcoma tumor board, and so we discussed giving salvage radiotherapy with concurrent chemotherapy in this point to try to achieve some sort of control. Unfortunately, before we could even start radiation therapy, she continued to have progression and had to require urgent tracheostomy, which is a connection directly to the airway so she could breathe better. And we had to rapidly replan her case. You can see here, this is the complete extent of the tumor continuing to progress from right to left, as well as in the central area. Okay, so we ended up treating her with IMRT in this case. So unfortunately, one of the limitations of proton therapy is that it does take a little bit of time to plan because it is a little bit more complex technique. There was not enough time in this case to get her over to a dedicated proton center and go through all the planning. So we did stick with IMRT, which is also an advanced modality, but a little bit less so than proton therapy. And I just wanted to show you what my final volume in 3 dimensions was, in this case, outlined in the red. And our dose in this case was 45 gray and 15 fractions, which is more of a hypofractionated approach, as we were talking about earlier in this webinar. We chose this dose because she had received prior radiation in the past. So even with good complex IMRT planning, here I'm showing you the red areas kind of represents our prescription dose of what we're trying to give to the tumor. But even with IMRT, there's low dose that is spread to the normal tissue. So I've brought the minimum dose down to 25 gray. You can see that the side of the neck is receiving 25 gray, and it's outside of the volume that we're trying to treat, give the full dose to. And that's just that's just unfortunate. That's some of the limitations of radiotherapy, and this is just how it works that proton therapy can overcome. So my question is that I would like to address with the panel is, would proton therapy have helped in this case? I'd like to open it up
I'd like to ask
to the floor.
Dr. and others, so how things would have been different?
I think so. I think as shown by Dr. Matt in his previous case, of course, in head and neck side, proton would be really helpful, but that is a general statement. This is a midline tumor. Normally, I've seen that proton therapy is really beneficial if it is on one side, on ipsilateral targets, to be, give a really good dosimetric benefit. In central target, I feel that the benefit is going to be less. Having said that, I'll have to see all the images and really, do probably a dosimetric comparison and how much am I gaining with protons, because proton is a modality which is not very accessible. So I would not wanting to push proton for everyone. So I would probably ask for images, do a proper dosimetric comparison and see if it is really beneficial. If it is a young patient, I'm sorry, I've not got the age of the patient. What was the age of the patient?
She was in her 60s.
60s, yeah. 60s, and many things come into play, the logistics and where the patient is from, how far is the patient from a proton center, would she have to travel, how much is the benefit, and so on and so forth. So I think, so all these things would help me take a decision.
Yeah, 100%. And, in this case, she is a lady who's had multiple neck dissections, multiple neck resections. When you go through that, you already have difficulties with some of your mobility of your neck muscles, and she has also had radiation to the neck area as well, which also can limit some of your movements and whatnot.
So yeah,
in this
if
case,
if it's a re-radiation, then yes, proton would certainly be of great benefit.
Yeah, this is a re-irradiation and multiple re-resection case.
So as a basic question, what comes to my mind for Dr. Matt. So if a patient has come and you have to consider for radiation. So now, since you have this facility of proton therapy, so do you advocate proton in every patient, or you choose your patient who can go for conventional? How do you decide that?
That's a great question. I think I just wanted to add that point, so I'm happy you brought that up. I think that in a place where we have a photon or IMRT or VMAT machine and a proton machine in the same center, literally down the hallway from it, that we have the opportunity to make what we call a comparison plan. So in this kind of a case, what we would likely do is we would bring the patient in, do a planning CT scan, which we do for every case of radiation, and we would basically plan it in a way that we could use either modality. And then we'd have our dosimetry planners who are kind of, they're part of our staff that help us plan the radiation. We'd have them basically make the best plan they could for a non-proton and then a proton. And it actually sometimes turns out that treating the patient without proton therapy can sometimes be better. And it really depends on where the prior radiation plan treated, where the doses fall, and then just to reiterate the point made before, where the tumor is in the body. I definitely agree that when things are central or more towards the middle of the body, there's less of an advantage for protons. One other quick point to make is that we haven't talked very much about when we treat radiation day to day over time, we use imaging to help make sure that we're delivering the dose accurately. Is it going to the right place in the patient? The imaging that's available to us on our machine versus our VMAT machine is different. And sometimes in some parts of the body, mainly like in the pelvis or in the abdomen where things are moving a lot, having better imaging may help you. So sometimes that plays into the decision as well about which treatment that I would use.
Okay. So we can move on to the next case by Dr. Arpit. So Dr. Arpit, please go ahead.
Very much. Let me share my screen. Please let me know if you cannot see my slides. Okay. Can everyone see that? All right, so I'd like to, I'm gonna briefly present here a case of a patient who has what is known as a chordoma, which is a, as Dr. Vivek sort of initially alluded to, a malignant type of sarcoma that's arising from the spine. This is a case that we treated here at the New York Proton Center. So the patient's history is he's a 63-year-old gentleman. He had a chordoma, as I alluded to, arising from the left portion of his vertebral column, primarily in the upper thoracic area. So in the upper sort of chest region, from T3 to T5 specifically. How this sort of arose and how he came about this diagnosis sort of dates back a few years. You know, he originally was diagnosed actually with a colon cancer that was in August of 2018. And for that colon cancer, he originally underwent surgery, which is generally the standard way of curing colon cancers. He had a phenomenal surgery. At that time, there was no indication, no recommendation to get any other therapy for his colon cancer. But generally, for most cancers in the body, most tumors, you will tend to do additional imaging at the time that a tumor is diagnosed to make sure that that tumor is not found to be anywhere else, that there is no metastasis, as we've been talking about with many of our other cases. And in that process, the patient had a CAT scan done to make sure that his colon cancer was not anywhere within his chest, and it was not. But what they found on this CAT scan, and this does happen sometimes when you do imaging, is you find things that are incidental, things that are not causing the patient any problems or any symptoms, but they are something that you find when you start to do additional imaging and you start to look. What they found was in the upper left lung, a specific type of tumor. It's a very, very slow growing tumor and many times does not grow at all in a patient's lifetime. Which can generally be managed by just observation. And that's what he was recommended for that type of specific tumor, is just observation. And for that type of tumor, he underwent additional imaging about a year later. That was summer of last year. And at that time, they found that the tumor was relatively pretty stable in the left lung, but a new finding had developed, and that was a new paraspinal mass that was of concern. For this paraspinal mass and any sort of mass that arises near the spinal cord and the vertebral column, which is down the midline of the back, as I'll show in a minute. MRIs are very helpful, and really for any sarcomas, MRIs are the most optimal modality of imaging. What they found is MRI did confirm that there was a left paraspinal mass arising, as I mentioned, from the upper chest, upper thoracic area. But what was of most concern is that this tumor was sort of invading very significantly into the canal and pushing the spinal cord, as I'll show here on the next slide, at these regions. So I just want to sort of set the pictures here and set the context so everyone can understand. How you're seeing this is the patient is laying on the table. This is the back of the patient. This is the front of the patient. This is the left side of the patient, and this is the right side of the patient. And you're basically looking at individual slices going from the top of the patient to the bottom. And I've just shown 3 pictures, but obviously there's many more pictures in between. And one of the few areas that I want to show that are important are, this is bone here, and this is bone here as well. This is what's called the vertebral column. This is the column that protects your spinal cord, which is this region right here. And your spinal cord is a critical organ, as Dr. Srinivas mentioned earlier in our talk. It's a critical organ in that it serves a lot of function. It is highly important in obviously sensation and motor and strength of all of your extremities, including also control of your bowels and your urinary tract. I mean, it just serves a significant number of functions. And so it's an organ that needs to be protected at all times. However, as you can see, this was a tumor that was arising right here within the left portion of the paraspinal region. And on this second picture, you can see how it's pushing and sitting right next to the spinal cord. And so obviously that in itself can be very detrimental and obviously put the patient at risk of significant toxicity. So as you can see here from the pictures, this is sort of the degree of the tumor. At the time, the patient was originally seen by a neurosurgeon, and the recommendation generally for these tumors is to go in and take them out, especially because of the significant amount of cord displacement or the involvement of the cord. And that's what the patient had done earlier this year, a pretty extensive surgery, which confirmed that this was a chordoma. They did a very excellent surgery, and actually on the post-surgical MRI, which you can see here, there's really no evidence of any tumor. You can see that the spinal cord has sort of come back down into the midline here, which is where it should be sitting. And so this kind of raises that same question that Dr. Vivek had mentioned earlier, is why in this situation, when there's no tumor left after the operation, would you need to do any form of radiation? And the reason really is chordomas have a very high risk of coming back despite these operations. Because they're so intricately involved neuronal structures, it's very difficult to remove them in one piece. And even when you do remove them in one piece with no leftover tissue, the risk of it coming back is relatively pretty high. And so for that reason, radiation is generally recommended. It's also more easily controlled when you give radiation at the time of the first operation than if you try to give it in the event it does come back. So for that reason, we recommend it in the upfront setting. The reason we recommend a proton therapy for these tumors, and again, I just want to show these images. These are, again, just highlighting the surgical changes and the surgical hardware and the screws that were put in, and then obviously seeing the spinal cord here again down in the middle. But this is the radiation plan. And the reason radiation and proton radiation specifically is recommended for these tumors is because these tumors require very, very high doses of radiation treatments to control. On the order of 70 plus gray, kind of like the osteosarcoma case that we initially talked about. However, one of the very limiting structures around these regions is the spinal cord itself, because the spinal cord cannot take 70 gray without us putting the patient at undue risk of side effects. And because the spinal cord can only tolerate a much lower dose in these scenarios while we're trying to give much higher doses to an area right around the spinal cord, that sort of phenomenon of the Bragg peak and the minimal exit and the sharp fall off really help us tremendously in these scenarios to be able to give the doses that we need to make sure this tumor has the lowest chance of coming back while really trying to protect normal structures, including the spinal cord. And so in this case, we did elect to give 70.2 gray. We initially gave sort of a two-phased approach. We gave 50 gray first and then 19.8 gray second. And that's what's highlighted here. So this is the 50 gray initially to a much larger area. to ensure that we cover all the areas that might have contaminated microscopic cells. And the 19.8 gray sort of comes down and really just focuses on the area that's at highest risk. And that's the area here where the tumor originally began, as you saw on the pre-surgery MRI. What I want to highlight here is the red is the volume that we tried to treat. And right here in this small circle is that spinal cord, as I showed you. You can see that they're basically touching one another, and you want to try to use that sharp fall off to be able to give the 70 gray, but then not get anything even close to 70 gray to this spinal cord here. The other point I want to highlight is not is the spinal cord the only organ that we're trying to spare. You can see that the amount of dose that's getting to the lungs, to the esophagus, which is this organ through which we eat and swallow, to the heart, which is here, and then to the rest of the body is all significantly much less than it would be with any form of X-rays or photon radiation. So thankfully, the patient did extremely well. Apart from, again, some mild redness on the back, really had no issues. And at this point has already had one MRI post-radiation and remains sort of tumor-free at this time point, and hope that continues. That's my case. Thank you very much.
Interesting case, Dr. Arpit. Just one question. What was the neurological status of the patient?
So the patient was developing back pain. The patient did also have some degree of neuropathy in the left extremity, but it was predominantly pain that was eliciting the symptoms here and sort of the diagnoses.
Dr. Akshay, as a surgeon, what is your opinion about when there are spinal tumors which are involving the cord? So the combined role, surgical decompression, only radiotherapy.
Okay, thanks, Vivek. I think I'm audible. Yeah.
Yeah, you are audible.
Yeah. So basically, we look at two kinds of surgeries for bone cancer. One is a wide excision where you want to just sort of take the whole thing en bloc with wide margins without actually entering the tumor. And the second is when you want to debulk and take the tumor out in pieces and then try and take the whole thing out. And as Arpit just pointed out, this was not just touching the cord, but also pushing it to one side. And a complete removal, surgical removal in a single piece is not feasible in such situations. And that is where you are forced to do a piecemeal excision. And this obviously leads to spillage of tumor cells, and you cannot expect surgery to deliver very good results in the long run. And that is where I think therapies like proton therapy are going to be really, really useful. My question to Arpit and to Srinivas and also to Mudit and Matt is that we've been talking a bit about separation surgeries for spinal tumors with SBRT. Is proton going to remove the need for separation surgeries, or are they still relevant?
We can talk a little bit about that. I think that's an excellent point. Even with proton therapy, there is a limitation in how fast we can make the dose go from therapeutic dose to zero. Sorry, to be more clear, not fast, but over a certain amount of distance.
Yeah.
Right. So the distance is certainly shorter with proton therapy than with photon therapy like VMAT. But if there's tumor abutting the spinal cord, we cannot make it go from therapeutic dose to zero dose with no space. So I think there will always be a role for surgery in that sense.
Okay, so if I may ask, in this situation, yeah, please.
I was going to add one thing that we should clarify is when we're discussing separation surgery and spine SBRT, we're not talking about it in a primary chordoma setting. So that's typically talked about for a bone metastasis, which you're giving. Yeah, so in this specific case that we've been discussing, it would not come into play because SBRT is not an established treatment for chordoma. But like Dr. Spraker said, we want to make sure that the dose fall off is not in the spinal cord itself. And so the separation surgery allows us to have more confidence with that.
So Dr. Akshay, we do, we don't call it as separation surgery, but we call them as decompressive surgeries. We have done a few cases of clival chordomas where there is significant brainstem compression. So kind of a surgeon goes in and decompresses a portion of chordoma, which is into the prepontine cistern, pushing away the brainstem. Even in the situations, even in rarely in cervical or dorsal chordomas, wherever we see, when it is pushing pleura away, cord away, some kind of a decompressive surgery. Of course, the surgeries can be done in toto, massive, as you widely mentioned, the wide excision, it's definitely preferred. But we do this kind of separation surgeries in situations where they are massive and we are not able to do a complete excision, and there is a brainstem organ compression or a pushing away, and we try to do because as Dr. Matt mentioned, whatever you use, whether you use proton or X-rays, you do still need some separation from the OAR. Despite proton, you will never be able to achieve the kind of doses which you want to achieve, especially in tumors such as chordomas.
Yeah, so as a surgeon, see the basic difference that a surgeon feels is there between a decompression, a complete gross complete excision, and a separation surgery is that if the radiation oncologist tells me that if you just remove the tumor that is just next to the cord, I'll take care of the rest of it, because I can deliver good dose there. And where ultimately you are going to depend only on proton therapy, you would be better off taking tumor which is just next to the cord, and then maybe you could have avoided a corpectomy here. My question was pertaining to whether you would still prefer a complete corpectomy and gross total removal even with proton, or you would be happy just the tumor next to the cord being removed.
Dr. Akshay, I would be happy to send it to my surgeon on any day for any chordomas, any sarcomas. As you rightly said, surgery is the key. There's no doubt about it. And we irradiate in a post-operative situation for a microscopic disease, the outcomes are going to be definitely better compared to irradiating a gross tumor. So whether it's a clival or the dorsal or cervical or any spinal chordomas, I would always push for surgery if feasible, whatever surgery is feasible. Of course, in sarcomas, R1 or R0 resections are definitely very commonly practiced, but for chordomas, it's very challenging, as you know. So I would accept an R2 resection in chordomas, but always surgery is the key. There's no doubt about it.
I just want to add to that so not to get too technical here, but actually many studies have looked at the outcomes of chordomas getting proton radiotherapy and how much tumor was there at the time that the proton started. It's been shown that the smaller the amount of tumor that's there is significantly better than the larger amount. And that's not just because the space is more from normal cord or brainstem and how much dose you can give, but it's just a sheer function of the less cancer cells you have in an area that you are treating, the higher the likelihood you're going to do better. So for any situation, as you alluded to, Dr. Srivanas alluded to, not only do we want the surgeon to help us give us some space, but at the same time, we want the surgeon to help us to try to get as much of it out as we safely can.
Great, thank you.
Right. So I think we have done with the discussion. Dr. Srinivas, can you briefly summarize the role of proton therapy in sarcomas?
So proton therapy is one of the many modalities available for sarcomas. It is definitely not a panacea, especially because it is available only in few places. It is still a bit expensive compared to the conventional radiation techniques. It is imperative to choose which patients should be subjected to this new treatment. And it is our responsibility as physicians, all of us, to educate the patients. And that is the whole purpose of this support group meeting. And in sarcomas, by and large, is a favored indication for proton therapy, because as everybody mentioned, the dose required to sterilize sarcomas, whether it is in a post-operative setting or in a definitive setting, the dose required is relatively large compared to other tumors. And it is very important to make sure that this dose is delivered safely without causing long-term effects on the body. Most of these sarcomas are affected in patients who are younger, and that is primarily the reason why proton therapy is extremely beneficial. Having said that, a large majority of sarcomas do benefit for proton therapy. Having said that, there is not, I mean, you cannot generalize it. In this day and age, you must never generalize anything. It has to be individualized. It has to be a decision which is taken with the patient in the center of the treatment decision, with the surgeon, radiation oncologist, radiologist, pathologist, everybody in place. We haven't discussed the impact of metal artifacts on proton therapy dose distribution, but that is the reason why surgeon, before putting in a lot of heavy metals, must also discuss the other options he could offer to the patient, especially in these spinal chordomas, because the metal brings in a lot of uncertainty in proton dose. And sometimes if it is too much, we would avoid using proton therapy despite having a significant dosimetric benefit. Of course, we have ways and means to overcome those uncertainties because of these heavy metals. But despite that, this is the reason why I'm mentioning this, is to emphasize that there is a team effort which is required in managing sarcomas, especially when it comes to proton therapy. And that is all I wanted to say.
Thank you. So it was very well summarized about the role of protons. So now I think I hand over to Ms. Priyanka Banga. So if she has, as a patient's advocate, she has any questions, any comments, she can put it up to all of us. You are muted.
Thank you so much, Dr. Vivek. Thank you to the panelists for such a wonderful discussion, such a detailed discussion. It was very, very informative. Being a non-medico, I was totally glued to all your points that you were raising, the cross-questioning. Thank you for making it so informative for the general public. Coming from a patient advocate's perspective, I was noting down a few questions. What I would want to know is proton therapy covered under insurance in India? Dr. Srinivas?
See, most of the insurances do cover these, but the whole issue is that most of the people have insurance up to 5 lakhs or up to 10 lakh rupees, which is not sufficient to cover the entire course of treatment with proton. But some insurances, wherever they have insurances up to a much higher range, proton therapy has been approved by several private insurances. But as of today, unfortunately, most of the patients do pay from pocket in India. We do see patients coming from abroad as well, a lot of them. In fact, 40% of our patients have been from abroad. And all of them have had some insurances, either paid by the governments or by private insurers.
Thank you so much. Now that we are more than 2 years down the line with proton therapy in India, are we having any plan of government being involved to make it, with the government scheme, a bit more reachable to the general public? Because right now it is totally at the upscale.
Absolutely. Ms. Priyanka, this is a very good question. Hopefully with more proton therapy centers coming in, the footprint of proton therapy coming down, the cost of proton therapy is likely to come down significantly, hopefully in the future. But as of today, it is indeed nearly 8 to 10 times expensive than conventional radiation therapy techniques in India, which is unfortunate. The hospital, our hospital is trying to engage with governmental and insurance and everyone, all the stakeholders, to make sure that it is possible for right patient to receive this treatment. For example, Himachal Pradesh government has approved close to 4 or 5 patients whom we have treated. Of all of them were chordoma patients. In fact, all of them were paid by the government. So there is some, to degree, very little success we have started to see, but hopefully we will have to engage more, and hopefully the center in Tata Memorial, when it comes, that would open up larger avenues for more acceptability by the patient groups as well as the government and insurance and everyone.
What is the time frame of the treatment? Of course, it will depend on the case and the type of sarcoma, but generally, what is the bracket that we're talking about a proton therapy treatment, both
So,
in India and US?
So whether it is India or US, normally most of the fractionation is given over a period of 6 weeks. It ranges from 5 to 7 weeks. I'm sure that is the same in United States as well. Dr. Matt or Dr. Mudit, anyone can take it.
Is the time frame similar in US or?
So sorry, I wasn't able to hear for a few minutes. Could you say that one more time?
No, I said, yeah.
Yes,
in
Dr.
India,
Srinivas.
yeah, in India, we most of the fractionation we use for sarcomas is between 5 to 7 weeks, which is typical. Typical fractionation used in India. And what about in US? I'm sure it's the same.
Yeah, it is the same. So for a preoperative setting, we usually try to give 50 gray and 25 fractions. That's the standard approach. And for postoperative, it ranges from a minimum dose of 60 gray and 30 fractions, and then going upwards based on some of the details of the surgery. For example, like how much, if any, is left behind. So that's kind of what we've historically done our dosing off of. More recently, there are some smaller studies, some single institutional studies that are looking to shorten that dosing scheme. So kind of in a 5 fraction regimen actually. So we're seeing anywhere from 30 gray and 5 fractions and higher in the preoperative setting. But that's we have to be careful in applying that for all of our patients, as that is still considered experimental and very, very new. So again, the standard dosing is, I completely agree with you, over 5 to 6 weeks.
Thank you. And I have one last question, which will be open to the panelists. What are the points one should consider before finalizing proton therapy as a line of treatment?
I can speak a little bit about our process at our center for this. So when we do have a patient that comes in that's a candidate for proton therapy, we actually have a team that reviews the cases, sort of to triage the case to make sure that it's appropriate. And then in the United States, insurance coverage is often a point of discussion because I think in a lot of instances, there's a little bit of a resistance to offering proton therapy because of the cost or covering proton therapy because of the cost. So we think a little bit about that as well. And then the last thing that we think about is benefit and any challenges with the case. So what I mean by that is we talked about how patients with lateralized tumors or tumors on the side of the body versus the middle, those are ideal cases for proton therapy. But there are some cases that are challenging as well. For example, if patients have medical devices that are implanted near where we might be radiating, that might be something where we, what I mean by that is like a pacemaker or metal things, like sometimes with spinal surgeries, we'll see metal pieces put in to help stabilize the area after the surgery. Those can sometimes make it challenging to model proton therapy dose in our computers. And those might be cases where we would actually end up not using it because it might not be as good in that case. So that's the process that we use to think about how we ideally select patients for proton therapy, among other factors that have kind of been discussed. And then once that's done and we agree that it's a good case, we would proceed forward with treatment planning and go from there.
I think in addition to add to what Dr. Sprecher said, which I completely agree with, is as a patient, especially in the United States, but also certainly in India, where the number of proton centers are limited, is from a patient standpoint, being an advocate for yourself and really talking in truth and sort of just talking also just very specifically with your radiation oncologist about cost, about affordability, about the ability to travel the distance or stay away from home for the duration that you may need to, and using all of those elements and really having a very frank conversation with your radiation oncologist about the degree of benefit that protons in your specific case would allow, and sort of balancing all of the clinical and non-clinical factors that should go into it.
Thank you,
Priyanka,
Doctor.
if I may add, normally what we are doing is we receive a lot of inquiries either from patients or doctors themselves, either radiation oncologists or orthopedic surgeons. Either they send us an email or call us or send something on WhatsApp, images. We get all the images. We try to quantify the benefit, because we don't want to invite everyone to Proton Center. This is the only center available. We want to make a preliminary kind of a discussion, as Dr. Matt mentioned, kind of a triaging, whether this patient would be likely to benefit with Proton, and then would convey the same to the patient or to the doctor. And then once the patient makes a decision that yes, Proton is indeed an option for the patient, then they come to Chennai. Then we have a detailed discussion, detailed evaluation of the imaging, on MDT discussion, and whether Proton would be really beneficial and how much would be of benefit, what is the cost benefit ratio. And based on that, the patient takes a decision whether or not he or she would like to go for proton therapy. Then we go ahead and treat. And as Dr. Matt mentioned, most of the steps beautifully well. So we do the same here at our center in Chennai.
That was a very valid explanation, Dr. Srinivas. Thank you so much. We sitting in North India, and the Proton Center in India available at Chennai, which is to the south of India, people who are faced with proton therapy as a line of treatment usually come up with a question: can it not be cured by radiation? Do I really need proton? To convince them at that point, the logic that you've put forward goes a long way. Thank you so much. With that, we would come to a wrap of this webinar. But before we log out, I would just like to share a few things about Sarcoma Cancer Care Foundation. What we are doing here in Delhi, we are basically taking care of 5 parameters: awareness, detection, treatment, rehabilitation, and survivorship. Now, in awareness, we hold awareness camps, be it radio, be it colleges, be it other public places as per the guidelines of the hospitals. In detection, we handhold the patients for getting the appropriate tests done if they're not being done in the hospitals that they're getting their treatment in. Supposing, if we talk about the underprivileged, we treat, we take up patients from AIMS New Delhi and Safdarjung New Delhi, which usually there is a crisis on dates availability for the tests. So we have to get it done from the private diagnostic centers. We help them with it. And after that, the treatment, once the treatment starts, there's a lot of counseling that needs to be done. And also things have to be taken care of, how to counter the side effects of radiation or chemotherapy, or the changes that happen in the body post-surgery. So we assist patient, handhold the patient in their treatment there. Rehabilitation, we are basically faced with 2 verticals: children or adults. Now, children, because of their prolonged treatment, are unable to go back to school or appear for their annual examinations because of their attendance or other issues, which should not be a criteria. So we assist them in getting back to the school life and to their classes and to enroll for the exams. For adults, we have job opportunities according to their credentials, according to their competitiveness. We assist them in getting back to their career life. For survivorship, once they are back rehabilitated, the journey does not stop there. To cope up with the, I would avoid saying new normal, but to cope up with the challenges faced post-rehabilitation, it takes about a year or 2 for hand-holding and for the coping of the challenges faced next. So we are assisting patients in those categories also. Apart from this, we are arranging for blood accommodation for the patients who are not stationed in Delhi and who come from outside Delhi for the treatment. We've also started a pharmacy bank where we provide medicines either free of cost or at 50% discount, totally on the written recommendation of the doctor treating them. Well, this is, we've recently added health insurance as a criteria where we encourage people who are I mean, not currently into treatment, but who would like to take health insurances to their for their families and for their loved ones through us, because whatever remunerations we get goes to Sarcoma Care Foundation, which we again use for patient benefits only. So instead of asking for donations, we ask people to take insurance policies from us and help us assist the patients. So this is a short description of our work that we're doing. Any support needed, please do get in touch with us. Would request the doctors also to recommend patients to us if you think we can support them in any way. Dr. Vivek, I think with your permission, we would now like to log out and thank everybody for your participation and your time, especially the weekend morning for the US and the evening for the Indians. Thank you so much.
Thank you, everyone. Thank you for your participation.
Thank you.
Thank you.
With that, we'll just log out. Thank you.
Bye-bye.